Thank you for joining us today. My name is Maritza Dowling, and on behalf of the Center for Aging, Health, and Humanities and the School of Nursing at George Washington University, I would like to welcome you to the 5th webinar of our webinar series on building dementia-friendly cities and communities. There will be a question and answer session at the end of the presentation. So questions for the Q&A discussion can be placed into the chat box anytime from the beginning until the end of the presentation. Today, I am delighted to introduce Dr. Catherine Posin. Dr. Posin is a John Douglas French Alzheimer's Foundation endowed professor in the Department of Neurology at the University of California in San Francisco. The Memory and Aging Center and the Wales Center, or Institute for Neurosciences. Dr. Posin research focuses on improving diagnosis and care for patients with neurological disorders. She has investigated the brain basis of cognitive decline, developed novel and practical methods for measuring cognition, and advance new models of dementia care. She has two major projects in this area of dementia care. One of these projects is the University of California, San Francisco, or UCSF Brain Health Assessment, which uses a software program to improve diagnosis. Another project is the Care Ecosystem, which is a telephone-based care and intervention funded by an R01 from NIH, the National Institute on Aging. So today, Dr. Posin will be talking to us about the second project, the Care Ecosystem, developed as a model of dementia care and designed to provide personalized, cost-efficient care to those affected by dementia and their caregivers. So now I would like to turn it over to Dr. Posin.
Yeah, thank you, Maritza, so much. It's really great to be here today and to get to talk with all of you about our program, our attempt to try to improve dementia care. So I'm going to start by trying to show an introductory video of the care ecosystem. Sometimes videos don't work that well over Zoom, so just send me a note in the chat if it's just too choppy, and we'll just move on with our PowerPoint slides. But let's give it a try and see if it works, because I think it provides a nice introduction to our program.
I was in a meeting at the University of California, San Francisco, when the staff who had designed the program called the Care Ecosystem announced it. I remember tearing up and saying, "Dear God, it's the answer to all my prayers."
The team that developed the Care Ecosystem, including myself, we work at an academic medical center where we have a lot of dementia specialists and we're able to provide really good dementia care. We wanted to design a model of care that could reach patients with dementia wherever they live.
Within healthcare systems, there are people with dementia and their caregivers who are kind of floating out there without the support that they need.
For most patients who have dementia, they receive their diagnosis from primary care. Maybe they see a neurologist. But for the most part, they're left on their own as they try to navigate the challenges of dementia.
Research has shown that primary care providers actually don't feel confident and they don't feel like they have the time to really adequately address the problems that come up with dementia, the issues that come up.
When my father was first diagnosed with a dementia, we got nothing outside of the diagnosis. There wasn't a leaflet that said, "Here's the description of your disease." There wasn't a social worker. There wasn't a clinical nurse. There was nobody. We were given a diagnosis and sent home.
The lack of understanding of some symptoms of dementia might lead families to take their loved ones to the emergency room, not recognizing that a particular symptom is part of the diagnosis that they've already received. Or even when they do recognize it, they may not know how to diffuse the situation or manage that particular symptom.
To be able to have an access point to direct response on critical symptom management is beyond huge. It certainly kept my family out of the emergency room more than once.
The majority of the burdens in dementia are carried by the caregivers. These are usually members of the family, someone who loves the person with dementia. This is that workforce in dementia. We need them. They are the only workforce of sufficient size and distribution to manage dementia. But they didn't sign up for this role. They were not trained to take on this role. They have many other responsibilities. They may still work, for example. And we have a responsibility as our society to help those caregivers, to usher them into this role and support them as they take on the evolving challenges. This is what the care ecosystem does.
Care ecosystem relies on individualized care, finding out what they want and what they don't want as the dementia progresses, as their life progresses is really vital for being able to advocate for them and carry out their wishes, support their wishes.
I think the care ecosystem is unique in that we have the care team navigator who doesn't have medical experience, nursing experience, but we train them in about the issues that are really important in dementia care. And they can really provide a lot of contact with families. It can be very personalized.
I absolutely love my job as a care team navigator. I love working with the caregivers of patients with dementia and learning about their stories and their struggles and being able to help in any way that I can through this program.
When a concern goes beyond the scope of practice of the care team navigator, well, that's when the nurse, the social worker, the pharmacist, the treating doctor gets involved. In this way, the care ecosystem makes sure that all those licensed providers are practicing at the level that they were trained to.
CTNs gather a lot of information and are able to identify key issues and red flags, which they then alert to clinicians, and we can come together as a team and brainstorm strategies.
Physicians have more time to see patients in clinic, while other members of the team, are taking care of other aspect of the care through phone call conversation, telemedicine, telehealth appointments with patients, etc.
A care team navigator has to really know how to establish that rapport over the phone pretty quickly into the relationship if there's going to be trust built. That's a tremendous skill that they have.
We've kind of established that we can still deliver this sort of care and this high touch by phone. So if people are more in the advanced stage and can't come see their doctor, we can still provide that link and that contact with people and help them problem solve.
It really takes a village, and there's a team of people that really have to work together in a very harmonious and orchestrated way in order to provide the best possible care to people living with dementias and their family.
In dementia, the needs are complex. They are medical, they're social, legal, financial. So you need a multidisciplinary team to help manage all of those issues that can arise.
I am ever in awe at everybody's ability to be able to pull together resources and provide really a very compassionate and thoughtful care to our patients and their families.
It feels terrific to be part of the team because, well, for one thing, I feel like I'm doing something very, very worthwhile. Care ecosystem is really kind of redefining dementia care, taking it to another level in our community. And so to be part of that to me is really exciting.
We've tested the model of care in a rigorous randomized controlled trial. We've begun to implement the program in several health systems around the country. But the journey is really just beginning. And we're going to work on this until patients all over the country are receiving better dementia care.
Today, if not yesterday, is the time to start thinking very carefully about how we provide the best support for people with dementia.
Well, thank Thank
I'm
you.
very pleased to introduce Dr. Eric Whitaker as one of our presenters this year.
Sorry, let me stop that. Let's see. Now I'm going to get on with a more traditional PowerPoint presentation here. All right. Can you see the screen okay? Maritza's nodding. Good. Okay. So hopefully that video ran smoothly for you guys and gave you a little bit of an introduction to our program. We really designed that video because we want to reach out to health systems that might be looking to adopt a program like this and help them understand what it is about. And as you'll hear throughout my talk today, we're very interested in bridging the gap between the science of dementia care and real world practice. So my disclosures, I have some research funding that's outside the scope of the presented work, and then grants, as you can see listed. All right, so as you heard in the video and also now in this quote, caregivers experience a lot of struggles, and people living with dementia with the state of care right now. Here's a quote from Julie, a person living with early stage Alzheimer's. "It took nearly 4 years for us to get a diagnosis. The doctor told us it was Alzheimer's, that there was nothing he could do, and to come back in a year. We were at first devastated, then angry. I also have diabetes, and I got medication, education, and care management for that. Now I have a fatal brain disease, and I got diagnosed and adios. We have to do better." But unfortunately, dementia care is too often crisis-oriented and fragmented. People living with dementia experience frequent emergency department visits, preventable hospitalizations, multiple care transitions. They experience inappropriate and potentially harmful medication use. Many are taking more than 10 medications at a time with no real oversight of that long medication list. Aggressive end-of-life care, it's often inconsistent with what the patient wanted and expensive. Informal caregivers shoulder substantial burdens with minimal supports from our patient-centric healthcare models. And we know that when caregivers are depressed, people living with dementia use the emergency room more. The COVID-19 pandemic has disproportionately disrupted the lives of people living with dementia. And we know that dementia caregivers report high levels of emotional, physical strain. This is some data from the Alzheimer's Association, facts and figures. All right, so this is from a study that used care ecosystem data, and we looked at the relationship with baseline caregiver depression and then use of the emergency department by the person living with dementia. And in this longitudinal study that had 13% of caregivers depressed at baseline, having depression was associated with a 73% increase in rates of emergency room use. I think this just highlights one of the reasons why, even if you're thinking in a patient-centric way, it's important to also take care of the caregivers. Now, our health systems, of course, we have to think about money. And certainly there's reason to focus on dementia from an economic perspective. Dementia is among the most costly health conditions. In this seminal report by Michael Hurd and colleagues from RAND, they found that dementia was the most expensive condition to Medicare. And if we include out-of-pocket costs, the difference is far greater, with the cost 80% higher for dementia than for heart disease or for cancer. And in this study that a fellow did with me with a 100% sample of California Medicare fee-for-service data in 2015, she divided the dementia patients by their dementia subtype. And if you focus just on the blue lines, these are the costs to Medicare by dementia subtype. So we can see the average cost to Medicare for California Medicare beneficiaries in 2015 for Alzheimer's was $14,000 a year. Which is still quite a bit more than for people without dementia. But you can see Lewy body dementia is a very expensive subtype of dementia, as is vascular. So understanding the subtype and providing personalized care may be important as well. So in 2019, there was a new ADRD specific milestone, so put out by NINDS and NIA. So they put out these milestones for where research is needed. And there was a new one in 2019 that was to bridge the science practice gap by conducting implementation research with the goal of better and more widespread implementation of proven dementia care programs that effectively support persons with dementia and their caregivers. And this milestone was given 2 success criteria. 1, to write a white paper on proven dementia care programs, and 2, to establish a national consortium tasked with applied research to implement widely in everyday care settings these proven care programs. Well, the first success criteria has been achieved, and I'll share the results with you now. So the AHRQ published a systematic review, and the National Academies of Science, a consensus study report. And these reviews evaluated the evidence that care models were ready for broad dissemination and implementation. So these reports concluded that the evidence is sufficient to justify implementation of 2 types of interventions in a broad spectrum of community settings, with evaluation conducted to continue expanding the evidence base. These 2 types of proven dementia interventions are collaborative care models and multi-component caregiver support. So I'm going to be focusing on the first one, collaborative care models, because care ecosystem is an example of a collaborative care models. So collaborative care models, they use multidisciplinary teams to coordinate psychosocial and medical care, typically with a care navigator or manager as the primary point of contact. These programs emphasize immediate needs of the person living with dementia and their caregiver, often called a dyad, and they also prioritize proactive planning that's personalized to the dyad. So these programs have been shown to improve quality of life for the person living with dementia, caregiver well-being, health system level markers, including improvements in quality indicators and reducing emergency room visits. Components of effective dementia care, these types of models typically include care coordination, attention to safety, behavior management, management of coexisting conditions, connection to community resources, supporting and educating the caregiver, advanced care planning, and always staying flexible and tailoring the care to the care recipient's changing needs. When I was first embarking on the journey of developing the care ecosystem with the team at the UCSF Memory and Aging Center, this white paper was published, and it really had a big impact on me. So in this paper, they reviewed the more than 200 dementia caregiver interventions that have been tested in rigorous trials and shown to work. But then also that few of these programs have been translated for delivery in various service contexts and remain inaccessible to all the family caregivers in the US. So I realized when we were just starting to develop the care ecosystem that we needed to focus on scale from the beginning. We needed to design a care program that could truly be scaled to diverse health systems around the country. There are barriers to dissemination of effective dementia care, and it's important that we understand these so that we can address them. Upfront investment is required. When all the programs that we have worked with that have adopted the care ecosystem have had to have some source of funding to get started. They had to have a grant or a gift from a philanthropist. Those in almost all, not all, but almost all cases, that's what it was, a grant or a gift from a donor. And then once you're up and running, there are different opportunities for reimbursement, and Medicare is working so hard on this. And I know there are people working in the policy space, and I know people at Medicare who are determined to improve reimbursement for these types of programs. At this particular point in time, it is a struggle. There are billing codes like chronic care management or principal care management, but frankly, they don't reimburse enough, and they are hard to get. The programs we've been working with have been having trouble getting reimbursed. Some programs have found their health systems will fund the program because they increase their HCC coding for dementia, which then increases the risk-adjusted payments in Medicare Advantage programs. But more work is needed here. There's gaps in the dementia specialist workforce. There are not enough of these dementia expert nurses, geriatricians, social workers, pharmacists. We need more people going into this workforce, especially from diverse backgrounds who are committed to working in diverse communities. But yet the care ecosystem is designed to really maximize the impact of this workforce by putting that navigator front and center, and then making sure that those experts really are operating at the level they were trained for. I think we need to always be getting input and be driven by input from people living with dementia and their caregivers. They need to help us continue to design and think about how to implement these programs to best meet their needs. We need to do more work on the effectiveness of these interventions in key demographic subgroups. We don't know a lot about that yet. And actually those two reviews I showed you really highlighted this. We need to see, how do these programs work in race and ethnic minorities? How do they work in people with Down syndrome, for example? So I think I'll just stop there, and you can read the rest of the barriers there, and I'll move on. All right, so I believe that scientists have a critical role in bridging the science practice gap. So I used to think that my measure of success as a scientist was how many papers I published and what journals they were published in. But that's not what I think anymore. I am interested in having an impact on dementia care. And to do that, I have to help bridge this gap. Scientists too often expect that the implementation and dissemination of their interventions will be taken up by other parties. That's not usually the case. As scientists, we need to understand why this gap exists and trial implementation methods to bridge the gap. And we need to work with policymakers about the science so that they can help us guide practice change. So this is a very crude, but for me, important model for how I think about making an impact with science. So when I have a new intervention, like when the care ecosystem was a new intervention, I work on iterative development. I don't think that my first idea is the best idea. I get lots and lots of input and work with a team and get input from patients and caregivers and providers and keep improving. And we're still improving the care ecosystem all the time. It'll never be done. And we want to keep making it better. You have to do controlled research where you can really isolate the variables and see if it works. And so for that, we did a big randomized clinical trial that I'll show you the results from. Implementation science, you want to understand how the program can be implemented in different settings and does it work in different settings? And then always thinking about scale. And scale really shouldn't be all the way over here. It should be throughout. From the very beginning, you need to design your interventions so that they are going to be scalable. So now I'll shift to telling you more about the care ecosystem and some of the research that we have done. So the model of the care ecosystem has this care team navigator front and center. This is an unlicensed but trained dementia care guide who partners with a caseload of patients and caregivers, people living with dementia and their caregivers. We think of them as a dyad, and we work with them together. So a care team navigator might have a caseload of anywhere from 50 to 90 of these dyads. First and foremost, the care team navigator responds to their immediate needs. when something, a lot of the time, the care team navigator can address those needs because of all the resources that they have at their fingertips and the training they've gone through. But when it exceeds their scope, they triage and to someone with pharmacy, nursing, social work expertise, or coordinate care with other healthcare providers. In addition, the care team navigator works proactively with the dyad on upcoming challenges in care to try to shift the dementia care from a crisis-oriented to a planful, proactive approach. A care team navigator, we look for people who are friendly, empathic, organized, passionate about helping people. They don't have to have a healthcare background. Most of them haven't. The CTN is trained, supervised, and supported by the clinical team, usually supervised by a nurse. And the CTN provides telephone-based care coordination. I will say most of our care team navigators have been recent graduates from college, people who are planning to go on to graduate medical nursing school. And one of the things I'm most proud of is that most of our care team navigators have pursued a career in geriatrics. So I think that these care team navigators are going out there and addressing the problem that we need to, grow our dementia capable workforce. So these are recent graduates from college sometimes. I mean, sometimes they're older, but these are not experienced professionals. What's the experience that caregivers have with them? So we surveyed 273 caregivers about their satisfaction with their CTN. And I was really pleased with these. I mean, I think, 92% of them said they could nearly always trust their CTN. 79% felt they were knowledgeable, 90% that they were responsive. So I think for the most part, our caregivers have really valued this relationship and having a primary point of contact for all of their challenges around dementia. In general, our program focuses on 4 major themes, particularly with the proactive care, and that's medications. We do reduce potentially inappropriate medications, and we support issues with adherence, access to drugs. Caregiver support and education, providing what caregivers need when they need it. Decision-making. We help families plan ahead and know what they need to do to plan ahead for medical, legal, and financial decisions. And behavior. This actually wasn't a huge focus of our program when we first launched in 2014, 2015, but we learned it needed to be. Caregivers struggle with behavioral symptoms, and our team is well suited to help them figure out strategies to try. We did some iterative development of the care model early on. And again, we still are improving the care model, but there was very rapid improvement in the beginning. We got our grant to start, our first big grant to start this program from the Center for Medicare and Medicaid Innovation in September of 2014. A big month for me because my first child was also born that month. So it's very, very exciting time on both fronts. But we worked hard to develop the first version of the care model. And then we got input on it from caregiver satisfaction surveys. So caregivers, after they were in the program for 3 months, we surveyed them. What did they like? What did they not like? We would interview our clinical staff, including those care team navigators, and get regular input, what they thought was working or could be better. We have a family advisory council of caregivers who provide regular input. They continue to do this. And primary care focus groups. We had 9 of those. So this input allowed us to rapidly improve the care model. And then after that, it's remained relatively stable. It has improved, but mostly stable since September 2016. And we published sort of that iterative process in a PLOS Medicine article. So then the randomized clinical trial, we enrolled people from 2 hubs. One hub at University of California, San Francisco, one at the University of Nebraska Medical Center. It was important for us to be able to include people living in rural areas. And because the care is phone-based, we were able to enroll people that lived anywhere within those states. You can see this sort of a heat map of where people lived by zip code. So this is a summary of the randomized clinical trial. It was a 2-to-1 randomization scheme. So for every 2 people randomized to the treatment, 1 was randomized to usual care, and just completed surveys, and we also get their Medicare data. So after the outcome survey at baseline, they're randomized, and then those getting the treatment, 512 dyads, they were assigned a CTN. Then they got the care protocols. This is like the default order, but we really personalize it depending on the dyad's needs. Both groups did outcome surveys again at 6 months and 12 months. And based on those surveys, we significantly improved caregiver well-being, caregiver burden, caregiver depression in the treatment group relative to control. We improved patient quality of life, reduced emergency room visits. And also, this paper's under review, but we reduced potentially inappropriate medication use. We are currently analyzing the Medicare claims data for this trial, and but I can tell you it seems to be quite consistent with the findings from the surveys. So that's to come. We did an analysis of the costs of providing the care ecosystem, which is so important to health systems thinking about how to pay for this kind of care. And some of the key findings, I will say caveat is these costs were calculated within the context of our research program, which is not quite real world, but we did the best we could. I think we need to repeat this study in real world health systems that are doing this. But we found some key things, which is that the cost per patient per month is significantly lower if you have a larger caseload, not surprising. And we think a caseload of about 80 is appropriate for an experienced CTN, and a newer CTN or one with a more complex caseload. For example, if you have a caseload of people who don't speak English and you need to use an interpreter, then a caseload should be closer to 50. Also, we found that there's more costs in the beginning as you're starting up, and then costs start to come down as your team becomes more experienced and you're staffed up. We are shifting now to do a lot of work in collaborating with innovative health systems around the country that have come to us and said, we want to adapt and adopt this model of care for our patient population. These are 6 of those health systems. There are more, but these are the 6 that we are working the most closely with right now. So most of these programs started around 2017, 2018. They each with their own funding source that they had obtained, like a donor or a grant. For example, the Administration for Community Living was really important for a couple of these projects. And now we're hoping to get a grant from NIA that will allow us to further bolster these programs, study formally how they are implementing the care ecosystem, and is it effective in the hands of these real world and diverse healthcare systems. So I'm hoping we will get that grant soon, and we will be able to launch what I think will be a really important next step in our research. So we're always thinking about supporting health systems to improve their dementia care. That's our driving force from the beginning. We have this website, memory.ucsf.edu care ecosystem, and we keep all of our information there for health systems. That's where you could find that video you watched at the beginning, but there's a lot more there too, and we're always updating it. So for example, there's a training program for care team navigators. We made 60 short videos that the care team navigators can watch to learn key concepts. Here's some of the themes that they will learn about. Each of these has a quiz afterwards. So it's a fully built training program for navigators. We also make recommendations that CTN should be closely supervised by a dementia expert like a nurse or social worker or geriatrician. And they need to have, weekly debriefing sessions to review cases. So that's kind of our recommendation about how CTNs get trained. So when health systems approach us and say, hey, I heard about the care ecosystem, maybe we would like to consider implementing it. We direct them to the website. There's also a toolkit, which is a whole document to help health systems figure out if they are ready for this. And then, we usually will meet with them. Typically, Sarah's the clinical director right now. Usually Sarah and I will meet with the health system leaders to help them think through whether it's a good fit and what challenges they're facing. We also have these monthly meetings where any health systems who are adopting the care ecosystem, their teams come together, share their updates, what challenges they're having, share strategies, and we support each other. And we share tools. For example, most of us are using REDCap now to collect data and to support quality improvement. So we just share all of this and support each other. And it's a really nice community. And just to be clear, everything is free. And also we don't require health systems to do care ecosystem exactly the way that we did it. We might recommend that they think about doing it that way, but ultimately they can take pieces of it, they can change it, because our goal is to improve dementia care. So I hope you can imagine with me a future of dementia care. I think it can be a near future where following a concern for cognitive decline, usually in primary care, a patient's cognitive impairment will be detected, they're diagnosed, they're given appropriate treatment, and then they're quickly linked in with a collaborative care model where people living with dementia and caregivers are navigated by a care team that personalizes care goals to their needs and prioritizes quality of life. But there's the first part of that little infographic I showed you that we haven't talked about, and that's detection and diagnosis. And unfortunately, diagnosis of MCI and dementia are delayed. MCI and dementia are frequently not detected in primary care. Diagnosis is delayed until moderate or advanced stages in 50% or more of patients. Primary care providers are well situated to detect cognitive decline, but they face numerous barriers. And this is another really crucial gap we have to address in care. So this is from the Alzheimer's Association facts and figures, and it's the percentage of US seniors who report receiving regular preventative health care services for specified healthcare factors. So you can see blood pressure is really closely monitored in primary care, cholesterol, vaccinations. Problems with memory and thinking don't get a lot of attention in primary care right now. And why is it important to diagnose cognitive impairment? That gives you opportunities to improve medical care, to treat reversible causes, optimize meds, engage patients and their caregivers in planning ahead, to connect to supportive care, address safety issues, and identify candidates for clinical trials and disease-modifying therapies, which we're going to be seeing more and more of. And diagnosis is delayed, but it is delayed the most for racial and ethnic minorities. In this paper that was led by a postdoctoral fellow in my lab, she looked at 100% sample of California Medicare beneficiaries who had a new diagnosis of MCI or dementia. And she found that while 23% of non-Hispanic white beneficiaries were first diagnosed at the MCI stage, these rates were much lower for Hispanic, Black, and Asian beneficiaries. And really, the 23% is much too low in my opinion too, especially as we move towards an era of disease-modifying therapies. Also, racial and ethnic minorities were less likely to receive a comprehensive diagnostic evaluation. They were less likely to see a specialist be evaluated with appropriate laboratory tests, and receive neuroimaging. Asian and Hispanic beneficiaries residing in highly disadvantaged neighborhoods were also less likely to receive a comprehensive evaluation. So to address gaps in the detection and diagnosis of cognitive impairment, there was a consortium that was formed back in 2017 to address the unmet need to detect cognitive impairment, including dementia, in everyday clinical settings. And this is a consortium that I direct. And it's in response to a high priority recommendation presented at the ADRD Summit in 2016, 2019, and some of you may have been at the meeting last week in 2022 and saw that it's going to be a high priority recommendation again for this next 3 years. And here's how it was written in 2019: detect whether cognitive impairment is objectively present when a patient, care partner, or clinician reports cognitive or functional changes. So detect CID, detect cognitive impairment, including dementia, is the name of this small consortium that's working fiercely hard on this problem. There's 3 teams, one at Albert Einstein, one at Northwestern, and then also our team at UCSF. Each of us have a brief assessment that ranges from 5 to 10 minutes. Einstein's team uses a simple paper pencil paradigm, and then Northwestern and UCSF have tablet-based assessments. And we integrate with the EMR, which is so important for efficient care. And we have common EMR outcomes like trying to improve diagnosis. Some of our learnings, we just finished this paper where we looked at the key learnings from our consortium. It's in press with the Journal of Alzheimer's Disease. Oh, excuse me, I don't know why that advanced. There we go. And here's some of our key learnings that will be in this paper. Engage primary care partners in design. The results, I apologize, there must be some kind of timing with that slide, so I'll just tell you. The results must be easy to access in the electronic health record. Diagnosis must be linked to better care, and the paradigms must address the needs of the increasingly diverse older adult population. So here's a little infographic of our paradigm, which is called the TabCat Brain Health Assessment. So we have this software platform called TabCat. It works great if you need any cognitive assessments for your research studies or clinical care. Feel free to reach out to me. So what happens is after there's a concern, then the provider asks one of their medical assistants to administer the brain health assessment. It takes about 10 minutes. It's very easy to administer. Right after the assessment, the data syncs in with the EMR in the form of a text-based report that says what's the likelihood of cognitive impairment and guides that primary care provider on the next steps in care based on how the patient performed. This includes looking for reversible causes of cognitive impairment, engaging a care partner, disclosing findings in a compassionate way, connecting to resources, and making referrals. So when I was at the ADRD Summit last week, I interacted for the first time with someone named Ian Kremer, who from the LEAD Coalition, and he said something I thought really stuck with me. Diagnosis of dementia should be TACA. All right, so easy to remember acronym. It should be timely, accurate, compassionate, and actionable. And he emphasized that we need to do better with that compassionate piece. And I think he's right. So I'm starting to develop a new care model called the Brain Health Consultation to provide an additional layer of care around the time of diagnosis. A dementia nurse has a phone call with the patient and their care partner following a primary care diagnosis of MCI or dementia, assess immediate needs, answer questions, and provide education about the condition, offer resources and referrals, and then communicate the findings and next steps to the PCP via the EMR. So while it would be ideal to empower PCPs to do all of this, let's face it, they have so many barriers, including time and limited training. And I think at this point in time, we need an extra layer of support. So we're trying this with the dementia nurse. I also think that each time the PCP reads the note from the dementia nurse, it's improving their ability to provide care. So if in the future that nurse is not available for the consultation, the PCP will be more familiar with the steps to quality care. So let's return to this infographic again. So this is what I envision as what I hope is the near future of dementia care. After a concern is identified, the patient is evaluated and given appropriate treatment, and then linked to collaborative care that manages and supports their needs throughout the duration of the illness. And here's a quote from one of our caregivers. "My care navigator always cared about what was important to me. I was so busy taking care of the now, but she helped me think ahead, so I was prepared. I have felt a mosaic of emotions of grief and depression and stress. Her support has helped me cope." So I'll just end now with a quote from Katie Maslow. These treatments and care practices will neither prevent nor cure Alzheimer's or other dementias, but they will help to change the experience of people with the conditions and their family caregivers, helping them to manage and cope with the difficult situations caused by the conditions and live as well as possible despite them. So I want to also end by thanking my wonderful colleagues who inspire me every day at the Ucsf Memory and Aging Center. And I'd love to open it up to discussion. I see there's already some great questions in chat. I'd be happy to share the slides. And do you use technology to help care navigators find the community resources and supports? And I wonder if Stephanie Pun is willing for me to put her on the spot. So Stephanie is our newest social worker with the care ecosystem, and I asked if she would join today. Thank you for joining, Stephanie. Do you feel comfortable answering the question about how you organize the community resources?
Yeah, I can speak to that a little bit. And it's actually something that we've been working on recently, a lot of trying to revamp the resources and organize it in a way that will be helpful for actually everybody at the MAC, not just our care ecosystem. And we have, it's called we call it here like a wiki. It's like we call it our Macipedia, and we organize all our resources for patients and caregivers of dementia to make it accessible for CTN. So unfortunately, it's not actually accessible for caregivers, but CTNs and all of our team can use it and be able to like look through the resources and recommend them to the caregivers that we work with. And so that's kind of how we go about organizing our resources and giving them to caregivers and families.
And I see a question from Janet. So Janet, it's been mostly phone based. We sometimes do use video calls, but we often find that the caregivers prefer the phone. They can take the call while they're driving somewhere or picking up the house. But we do sometimes use video calls, but most of the caregivers just like the phone. And sometimes there's an in-person visit, like if the patient's coming to see the doctor, maybe the navigator will meet them there, but it's not required.
I have a question related to the first question, actually. And it's related to a promotion. How has the care ecosystem model been promoted among potential users? I mean, both patients and a patient caregiver diet. How do they learn about the existence of the care ecosystem model?
I love this question, and actually, this is something I've been working on a lot with Michelle, who's on this call too, which she's our new project manager. We're thinking about this in new ways. So I can say the way it's been done in the past, which is with a warm handoff from a provider. So whether it's the neurologist, the geriatrician, the PCP, but the referring provider does a warm handoff to our program. I can tell you the details on how we do that if you want, but that's how it's happened. One thing we're experimenting with now is because in some more underserved populations, like we're working with the Department of Health Services of LA County, and 70% of their patient population doesn't speak English. And we're having trouble like communicating to the caregiver and the patient, like what the care ecosystem is and helping them see that maybe it's valuable. we're actually thinking about producing some TikTok style videos that show caregivers and patients and navigators, really short, but something that they could look at in the doctor's office or on their own to give them a sense for what it's like. So that's a new idea we have, but we haven't put it into action yet. Welcome any other ideas.
Thank you. There are a couple more questions in the chat box that were just placed by Jacqueline and Kate.
Yeah, Jacqueline, do you want to just read the question? Or I can read it. So Jacqueline asked, if a PCP or other care provider refers to the care ecosystem, must the patient then become the patient of one of your physicians? If not, how do you fund the project? Well, at UCSF, where I work, all of our care ecosystem has been grant funded by NIH, the Administration for Community Living, and the Center for Medicare and Medicaid Innovation. I have not yet been successful in getting our health system to pay for it, although I hope that will happen in the future. So, and no, the patient doesn't need to become the patient of one of our physicians. We would like to collaborate with their usual care providers. So that's how that works. Let's see, it would love to see NIA require care ecosystems or other models be provided, as part of education and outreach course.
Yeah, what an interesting idea.
Yeah.
So they have money with $3.4 billion to spend. You know, it would be a wonderful thing for families to have access to, and could also be a pipeline for future research. So if you're not eligible for their study sites, I think the care ecosystem model, one area that, you know, you've got your 4 ideas, which I love the model, but one is also a pipeline to research that's not in your current model, but could be added in.
Yes, and I agree. Actually, I love this idea. I hadn't thought of it myself until last week at the ADRD Summit. A couple other people suggested this, but I think that when you provide good care and develop these trusted relationships, then people want to participate in research too.
Exactly.
So it's a great outcome to look at. And I couldn't agree more about thinking about how the ADRCs can help move this type of work forward as the standard of care. So let's do it, Kate. Let's figure it out. Oh, what's the biggest challenge for the care navigators? Is it their caseload, having enough time to serve each dyad? Well, that's a really good question. And I will say that I wish the navigators were here to answer your question first. Most of our navigators have found their role to be very rewarding. We've had a couple navigators who it wasn't a good fit for. It was too hard listening to these. It can be really hard listening to caregivers going through really tough things all day long, right? And sometimes navigators wish there was more they could do when the disease is not curable. So I think those are the biggest challenges. But we try to bring people into the roles that are well suited for that type of challenge. And we've tried to provide them with a lot of support and supervision.
I have a follow-up question on also regarding care team navigators. I'm interested, for those of us who are interested in caregiver or building caregiver self-efficacy, what strategies have you employed since this program started, this model started? What strategies have the care team navigators employed that have enhanced caregiver self-efficacy, that have proven really important in making this change in self-efficacy?
Yes. Okay. Well, I wish our clinical director was here to answer that question for you. In fact, there's even a paper that one of our previous clinical director, Jennifer Mariles, wrote on this topic about how the care ecosystem can improve self-efficacy. And it does. It's actually the first outcome to move. So if we look at all of our outcomes, self-efficacy for the caregiver jumps up very soon after enrollment. They feel empowered having this dementia care guide to work with. And I think it has to do with just feeling supported, feeling like they have someone to go to, they're not alone. When they need resources or education, that Navigator can help them find it. So just feeling supported and like they have what they need to face these challenges gives them a sense of self-efficacy.
Thank you. You have one more question from Shanna Kosh.
Can you provide more details on how you envision scaling your model? Well, so we continue to update our website by revamping our materials all the time. So for example, the training videos that are on there now are the second version. The first version, we got lots of input on. They were long PowerPoint videos. We revamped them. We're revamping the toolkit right now, which is a long document to guide health systems through the process. And so we just keep wanting to improve the tools. We also want to keep working with health systems via one-on-one meetings, as well as inviting them to these monthly meetings so that there can be this growing network. So that's part of our role in scaling the model. In addition, I love to speak to people who are working on health policy and trying to improve billing codes, reimbursement opportunities for this type of care. I think those are, and then I keep doing research to grow the evidence base that this works. It works for patients, it works for caregivers, it works for health systems, it works for payers.
And this idea of getting ADRCs and ADCs in the nation to incorporate something like this as part of their education core, that I think that's a fascinating idea that's worth exploring in the next AAIC 2022. Maybe even a special seminar on this topic might be a good idea, or a symposium where different ADCs with similar programs. I'm pretty sure that education cores across the nation have at least something similar. I'm pretty sure, and I know I'm very familiar with the Wisconsin ADRC, and I know that their education core is quite active, mostly in promoting these type of models among minorities, Blacks, and in Milwaukee. So there is a minority. They have a minority satellite, and some of these models might be really interesting for them to learn more about.
I think, this is Shauna, sorry, I think that ADRCs are unfortunately more underfunded than almost any other organization out there. I mean, the whole aging area agencies on aging are struggling mightily, you know, so I think they'd be in the same grant asking situation, whereas I think the health system pocketbook is much bigger, and maybe looking at where they're already working with the ADRCs, you know, on social determinants would be a nexus point to think about how you approach both together, if you will, or something like that. I just think it'll be a hard sell for ADRCs. Not that they don't love it, but how they would do it without funding.
Yeah, it looks like Kate has a comment in chat to clarify. And Kate, you're with the ACL, right? I think Kate Gordon's with ACL. Yeah.
So today, I'm here as an independent consultant in health policy, but I do provide consultancy to the Administration for Community Living in another part of my life. And often this acronym gets confusing. The ADRCs within the Aging Network are Aging and Disability Resource Centers, which are, as Shanna said, underfunded, and they do only a limited amount of work with persons with dementia. They do more work with caregivers, but they're underfunded, versus the Alzheimer's Disease Research Centers, which is what I was talking about earlier, which are the centers funded by the National Institutes of Health and Aging specifically, that are funnels for fantastic research like your own. But it is a very confusing set of terminologies trying to serve the same people often. And the ADRCs and the Aging Network are tapped often for community participatory research with the Alzheimer's disease research centers.
Yeah, and I was referring all the time about the Alzheimer's Disease Research Center and the Alzheimer's Disease Centers, ADCs also. So there are many ADCs in the nation as well. Yeah. Yeah, and I'm glad that you made a distinction between the two. Yeah, they're generally highly confused. Well, we have run out of time. This was a fantastic presentation. Thank you, Catherine, so much for sharing your knowledge with us. Thank you, everyone, for attending this webinar and for supporting our educational events. This has been wonderful. We're looking forward to your slides. Catherine, if you send it to me, I'll be happy to send it to the list of those who enrolled or registered in this presentation.
Okay.
And
sounds good. Well, it was a pleasure. Thank you so much for having me. Great to see all of you here today. And I hope we continue to work together to improve dementia care. I'm looking forward to that. We'll be in touch pretty soon. Okay. I have quite a lot of questions, lingering questions that we couldn't cover, but thanks and take care, everyone. All right. Bye-bye. Have a great day.